Hello, my name is Professor Pasi Jänne, and I'm a thoracic medical oncologist and the Senior Vice President for Translational Medicine at Dana-Farber Cancer Institute in Boston, USA. Welcome back to this modular educational activity entitled Overcoming EGFR-TKI Resistance, Emerging Therapies and Biomarker Strategies in Non-Small Cell Lung Cancer. In our first two modules, we covered the mechanisms of EGFR-TKI resistance, the latest advances in treating biomarker-selected patients with actionable resistance mechanisms, and emerging strategies for addressing unexplained EGFR-TKI resistance in non-small cell lung cancer. In this third and final module, we will focus on precision medicine post-EGFR-TKI, biomarker strategies, and advancing biomarker testing. As we heard in our previous modules, EGFR-TKIs have transformed outcomes in EGFR-mutant non-small cell lung cancer, but resistance inevitably develops and can occur in many different ways, presenting both a challenge and an opportunity. The challenge is the diversity of resistance mechanisms. These can arise through point mutations in EGFR, for example, EGFR C797S, gene amplifications, for example, MET amplification, gene fusions, for example, RET rearrangements, or protein overexpression, for example, in HER2, or through histologic transformation. The opportunity is the potential to use precision medicine to match patients with specific resistance patterns to appropriate targeted therapies or clinical trials. Tissue and or liquid biopsy can be performed at progression to identify biomarkers of resistance. Identifying resistance mechanisms helps clinicians choose the most effective second-line therapy, whether this be a targeted agent, a combination regimen, or a clinical trial, and avoids inappropriate treatment for patients unlikely to benefit. Now, what is the evidence of improved outcomes with this approach? A meta-analysis of approximately 85,000 clinical participants with various cancers showed that patients receiving biomarker-guided therapy have significantly better outcomes. Molecular testing can increase the identification of actionable targets and adoption of precision therapy, which is associated with improved overall survival compared to patients who receive limited or no testing. In non-small cell lung cancer, comprehensive genomic profiling can also support enrollment in biomarker-driven clinical trials, which is associated with improved survival. Each EGFR-TKI resistance mechanism reflects a distinctive biologic process requiring a tailored testing approach. NGS technology can comprehensively detect a range of genomic alterations at either the DNA or RNA level. These include mutations such as EGFR C797S that disrupts osimertinib binding, or EGFR-independent resistance mechanisms such as an acquired BRAF V600E mutation. NGS can also be used to detect amplifications such as MET or HER2, but for these alterations, FISH is often considered the gold standard. Gene fusions, such as those involving RET or ALK, are a rare cause of EGFR-TKI resistance and are optimally detected with an RNA-based NGS, but can also be identified with DNA-based NGS, IHC, or FISH. Protein overexpression, for example, MET or HER2, may occur independently of amplification and can be identified by immunohistochemistry, offering a useful complement to genomic testing. Multimodal testing, NGS, FISH, and IHC, is now considered the optimal approach for characterizing resistance after EGFR-TKI therapy, as it maximizes the likelihood of identifying a targetable resistance mechanism. Histologic assessment also remains essential for detection of resistance driven by lineage plasticity, such as transformation to small cell lung cancer. IASLC and ASCO guidelines have not been updated recently, so we will focus on the NCCN and ESMO guidelines. These guidelines recognize the importance of molecular testing in guiding therapy and include recommendations for both tissue and plasma testing. They also emphasize the need to obtain sufficient tissue for molecular analysis noting that rebiopsy may be needed in some cases. Liquid biopsy is included as an alternative methodology, but if results are negative, tissue testing is still needed. Broad molecular profiling, typically using an NGS-based method, is strongly recommended in NCCN and preferred in the ESMO guidelines. Both guidelines recommend a minimal panel of genes to be tested in patients with EGFR-mutant adenocarcinoma. These represent potentially actionable targets, and testing results should guide therapeutic decisions. At disease progression, NCCN guidelines recommend performing a tissue biopsy to evaluate histologic transformation and identify resistance mechanisms. A liquid biopsy can be considered, but it does not allow for histologic analysis and hence can miss some potentially targetable resistance mechanisms. As treatment options for EGFR-mutant non-small cell lung cancer continue to expand with new TKIs, ADCs, and combination strategies, our testing strategies must evolve just as quickly to ensure every patient has access to the most effective therapy. To keep pace, biomarker testing must evolve with these treatment advances. We can see how testing has evolved in several ways. Broader, more comprehensive genomic profiling using NGS captures both well-established and novel actionable mutations, fusions, and amplifications. Complementary tools such as FISH and IHC help detect amplifications or protein overexpression, determine eligibility for certain agents, including antibody-drug conjugates. Liquid biopsy can provide rapid real-time insights into emerging resistance. Patients may undergo multiple rounds of resistance profiling as their disease progresses. Using combined methods, i.e. a multimodal approach, ensures that each patient remains eligible for next-generation targeted therapies or clinical trials. In summary, we've highlighted the value of biomarker-driven precision medicine for matching patients with EGFR-TKI resistance to the most appropriate next treatment or clinical trial. The importance of distinguishing between EGFR-TKI resistance mechanisms and how different testing strategies support this, how guideline recommendations can inform molecular testing approaches, and finally, we emphasize the importance of continued evolution in biomarker testing to ensure that patients remain eligible for next-generation targeted therapies or clinical trials. In the next video, we'll take a deeper dive into how we can refine biomarker testing in patients with EGFR-TKI resistance.
Hello, everyone. My name is Professor Paul Hofman. I'm Professor of Pathology at the University Côte d'Azur and Head of the Laboratory of Clinical and Experimental Pathology at Louis Pasteur Hospital in France. In this section, we will discuss how we can refine biomarker strategies for non-small cell lung cancer, especially for patients with resistance to EGFR-TKIs. I will start by talking about how should biomarker testing be tailored by non-small cell lung cancer disease stage, and what strategies ensure a comprehensive assessment for therapy selection. To answer that, it's very important to recognize how the role of biomarker testing changes throughout the course of the disease. So the pathologists have a key role in tailoring biomarker testing across the disease continuum. In early stage, we need to consider to look for EGFR, ALK rearrangement, and PD-L1 status. But at disease progression, of course, we need to use NGS, DNA and RNA NGS, immunohistochemistry, and sometimes a FISH analysis. And for advanced metastatic non-small cell lung cancer, I think it's very crucial to use broader NGS-based profiling. There is a growing availability of targeted therapy now support the use of large panel NGS upfront rather than doing sequential single gene testing. The broad panels capture both established and emerging biomarkers, providing a more complete molecular picture. Large panel testing also makes more efficient use of samples, ensures timely access to results, and avoids delays from ordering follow-up tests. It can also be cost-effective if sufficient actionable targets are included. Multimodal testing approaches incorporate NGS plus FISH plus immunohistochemistry to ensure no resistance mechanism is missed. As discussed in video 1, each approach has a specific role. First of all, FISH is gold standard for detection of gene amplification, distinguishing focal gene level amplification from chromosomal polysomy. RNA-based NGS is preferred for gene fusion detection, as it identifies express fusion transcripts and can capture both known and also novel fusions. Immunohistochemistry can be used to assess protein overexpression, which may occur with and or without a gene level change. Immunohistochemistry also directly visualizes target heterogeneity within tissue architecture. Multimodal testing is particularly important for key drivers of EGFR-TKIs resistance, such as MET or HER2 amplification, overexpression. And finally, combining NGS plus immunohistochemistry plus FISH enables full molecular characterization to guide optimal therapy selection. To do a broad NGS approach is probably the best way to be able to capture all the genomic alteration in this patient, specifically at tumor progression. For that, probably a centralized molecular testing to enable regional implementation or large panel NGS molecular plus implement molecular tumor board is the best way to be able to capture all the genomic alteration and to do the best treatment decision making for these patients. So there is many emerging biomarker and testing strategies. And of course, the question is, should we do centralized molecular testing to enable regional implementation of large panel NGS? Is it possible to have a decentralization of this testing? The majority is probably to have a robust biomarker testing and to have an accreditation to be able to set up centralized molecular testing in order to detect all these emerging biomarkers at the same time. So the second question is, what are the main challenges in obtaining tissue for biomarkers testing, and how should clinicians balance liquid versus tissue biopsy? Tissue biopsy, of course, remains essential because it allows assessment of histological tissue architecture, crucial for detection of small cell lung cancer transformation, target heterogeneity, tumor cellularity, and features of the microenvironment, such as PD-L1 status. It enables detection of both gene and protein level EGFR-TKI resistance mechanisms, such as MET or HER2 overexpression. It also requires to determine eligibility for certain therapies, for example, TDXD or TDZO-V ADCs, which depends on immunohistochemistry. So, of course, tissue versus liquid biopsy for molecular profiling advanced non-small cell lung cancer is pivotal, but we know now that liquid biopsy has many advantages. There is a high concordance rate. There is a rapid turnaround time for getting the results. It's minimally invasive. We can repeat liquid biopsy over time. We can capture heterogeneity and clonal evolution. Of course, there is different disadvantages. Non-DNA biomarkers cannot be evaluable. There is an increased cost if used concurrently with tissue biopsy, and we have a false negative rate, of course. For the tissue biopsy, there is many advantages. There is a pathology. The assessment of DNA and non-DNA biomarker can be done. And finally, there is some limitations, such a longer turnaround time. There is some issue concerning the sample quality and quantity. Tissue biopsy is invasive. The repeat biopsy in low performance status is not possible in these patients, and maybe it's impossible to capture the heterogeneity of the cancer. What about the sequential versus concurrent approaches? Ultimately, it's not about choosing between liquid or tissue biopsy, but how we use both together. An integrated approach that combines liquid and tissue testing can improve detection and minimize delays that may occur with a sequential approach, meaning tissue then liquid. A liquid-first strategy can expedite results with follow-up tissue testing to confirm negative or ambiguous findings, but also probably concurrent tissue and liquid biopsy approach at the same time is the best way to try to capture all the genomic alteration at tumor progression. And the close communication, of course, between oncologists, pathologists, and interventional teams is critical to ensure samples are adequate to enable timely treatment decision. The third question, how are recent clinical trials influencing biomarker-guided treatment strategy in post-EGFR-TKIs non-small cell lung cancer? As resistance develops, treatment approaches can be broadly categorized as biomarker agnostic or biomarker guided. So traditional standard of care after EGFR-TKIs was platinum-based doublet chemotherapy, which is biomarker agnostic. The combination now of amivantamab plus lazertinib represents a translational bridge, since biomarkers such as MET selection is not required for its clinical use, but data from Chrysalis 2 show higher overall longer progression-free survival in patients with MET overexpression. And we know have data to support biomarker-driven strategy that target specific underlying resistance mechanisms. Trials such as Insight2, Savannah, and Sashi evaluated combination of MET TKIs plus osimertinib in patients selected based on MET amplification and or overexpression in the post-EGFR TKI setting. ADCs occupy a middle ground. Some ADCs require biomarker confirmation beyond EGFR, such as Teliso-V, TDXD, and others concurrently do not need that, such as the Dato-DXd. Ongoing biomarker development, such as TROP2, KISUS, NMR, digital pathology approach for Dato-DXd may refine this approach. Better outcomes have been seen in QCS NMR plus versus QCS NMR negative patients receiving Dato-DXd. A few key takeaways. Now, the pathologists, of course, are central to optimize biomarker testing across the non-small cell lung cancer continuum, coordinating multimodal strategies to ensure comprehensive and timely molecular profiling, repeated broad testing at progression with both tissue and liquid biopsy, multimodal testing maximize insight, combining NGS with immunohistochemistry and FISH for protein expression and gene amplification enables full molecular characterization and selection of targeted or ADC-based therapies. Tissue biopsy remains essential for histological, protein-level biomarkers and microenvironment assessment, while liquid biopsy complement with non-invasive real-time monitoring. And finally, future research focuses on expanding panels, real-time liquid analysis, and artificial intelligence guide biomarker detection and interpretation.
In this next part, Professor Hofman and I will review some of the key points raised in the last two videos and discuss how we can advance biomarker strategies in non-small cell lung cancer, especially after EGFR-TKI resistance. Professor Hofman, we know that non-small cell lung cancer treatment is evolving rapidly. What are the main challenges you see today in biomarker testing for patients with EGFR-TKI resistance?
So thank you for this great question. I think the main issue is be able to have a tissue biopsy at tumor progression, tissue biopsy of good quality and quantity. Integrating liquid and tissue biopsy is also a good approach. By combining these two approaches, we can improve detection and monitoring, but differences in sample quality and quantity often limit comprehensive testing, sometimes requiring minimal or targeted testing instead. We need also to facilitate multimodal testing. The choice between centralized and in-house on-site testing can affect the turnaround time, access, and consistency of results. We need to bridge the gap. There is still a disconnect between guideline recommendation, published data, and day-to-day clinical practice.
My standpoint, the challenges are the ability to do appropriate biopsies. Sometimes resistance or cancers grow in areas where biopsies are more challenging or maybe clinically not feasible. And that makes it hard to obviously obtain sufficient amount of tissue for appropriate biomarker testing. And there we typically reflex to a liquid biopsy, which is helpful and can certainly tell us about molecular mechanisms of resistance. Sometimes resistance occurs, for example, in the brain only, and there too, biopsies are typically not performed, and one needs to think of approaches, therapeutic approaches that cover resistance on a broader basis, since you can't perform biomarker testing. Let's move on to the next issue. Professor Hofman, can you outline the importance of a multidisciplinary approach and how it can be optimized?
I think we need to avoid to have a gap between the physicians and the pathologists, and this is the reason why precision medicine requires specialized knowledge that is best delivered via a well-coordinated and well-educated multidisciplinary team. The role for molecular tumor boards is pivotal since it brings together pathologists, molecular biologists, oncologists, and probably other specialty in the future, such as surgeons, for example, to interpret complex or rare biomarker findings and ensures better treatment decisions.
So let me ask you a question that I think will highlight some of these points. What do you do when you receive a bone biopsy for resistance testing?
Yeah, as you know, I mean, bone biopsy for the pathologist is not a so good biospecimen because we need to take care about the quality of DNA when we have bone marrow or bone biopsy. So it's sometimes difficult to do immunohistochemistry and NGS analysis in this kind of specimen. I would say that cytological specimen is very difficult to manage when we want to combine immunohistochemistry plus NGS plus fish analysis because the quantity and sometimes the quality of cytological specimen is not so good. And we know that on cytology, we cannot have the assessment of the microenvironment. So yes, depending of the biopsy, we can do all the different testing or some of these testings.
So these are important points that the team needs to communicate to one another.
Exactly, we need to communicate definitively very tightly with the physician, and the best way for us is to have, as of course, the tissue biopsy, but we need also to say to the physician when the tissue biopsy is of low quality of quantity to switch immediately to try to get a liquid biopsy in these patients.
Let's continue our discussion. As novel and emerging therapies such as ADCs become available, we need to ensure that patients receive the appropriate testing to enable them to benefit from these treatments. Professor Hofman, how can pathologists and oncologists work together to use biomarker testing to guide complex non-small cell lung cancer treatment decisions, particularly with ADCs and other emerging therapies?
Thank you. It's a critical point because we have now more and more different possibility to treat the patients, specifically tumor progression, targeted therapy, and or ADCs, and or immunotherapy, and so on. So the major issue is to be able to communicate between the physicians and the pathologists to assess the good biomarker and to get the results with a good turnaround time, meaning that we can use, of course, DNA on RNA NGS, but also different panel of immunohistochemistry. And of course, we can also include fish analysis.
I think from my perspective, one thing that I hope will continue to evolve over time is the issue of reflex testing versus testing that is requested by the treating physician. So in many institutions, reflex testing has been instituted, but not everywhere. So I think that may result in some delays, which are sometimes hard for the patient because we need to make treatment choices, and it's critical to have results in a timely manner. And that is also why there continues to need to be discussion between the treating oncologist and the pathologist to understand the turnaround times and what pieces of information will be available at what point in time. Now let's consider one final point. We've discussed the best case scenario, the multimodality testing, is carried out enables patients with EGFR-TKI resistance to have the best possible access to available therapies. For that to happen, we need an optimal testing workflow to integrate methods like IHC and FISH into routine clinical practice. And Professor Hofman, how can clinicians optimize the non-small cell lung cancer biomarker testing workflows to ensure actionable biomarker detection?
I think the optimization for non-small cell lung cancer workflow for better biomarker detection depends, of course, of the accessibility to have a tissue biopsy, and sometimes it's not possible to have this tissue biopsy. So I think to get an optimal workflow to ensure actionable results are ready before treatment decisions are made is very important. We need to definitively to have a broad NGS panel, not only at tumor progression, but also at diagnosis. And I will say now, not only in advanced stages, but also in early stages. And we need also to improve the turnaround times, of course, but it depends, of course, of the cost of this large NGS panel. We need also to have a very efficient process. Reflex testing is probably much better than to have a request on demand of the physicians. And of course, rapid on-site evaluation should help to reduce time to treatment initiation, but rapid on-site evaluation is not always available according to the workload of the pathologists. Multimodal testing is very important, and we need to consider combining NGS with immunohistochemistry and or FISH analysis, and of course to include liquid biopsy for comprehensive resistance profiling. And also, of course, we need to look for PD-L1 assessment, and this can be done in the routine care right now. Collaboration is critical. With increasing complexity, close teamwork between oncologists and pathologists is critical to ensure appropriate tests are carried out and material is used effectively. This increases the likelihood of detecting actionable biomarker and improving access to the therapy.
Yes, I'd like to echo that last point. Collaboration and communication is really key, and I'm often in touch with my pathology colleagues exactly on these specific issues that you brought up. Thank you, Professor Hofman, for your perspectives and for sharing these with us. In modules 1 and 2, we discussed the importance of assessing and addressing actionable EGFR-TKI resistance targets, such as MET and HER2 amplification or overexpression. And we also covered treatment strategies for patients without an identified EGFR-TKI resistance mechanism, including the use of combination agents and ADCs. And finally, in this concluding module, we've learned that each EGFR-TKI resistance mechanism represents a unique biological process, and each requires a tailored testing approach to accurately capture the gene or protein level changes. Pathologists have a key role in biomarker testing across the non-small cell lung cancer disease continuum, and optimal workflows to ensure actionable results are available before treatment decisions are made is also key. Navigating this complexity requires an ongoing effective collaboration between oncologists and pathologists to assure that we're able to deliver effective therapies for patients who have progressed on EGFR-TKIs. Thank you for following along with this Touch Clinical Perspectives activity. We hope you now have a clearer picture of how addressing actionable resistance, looking beyond actionable targets, and advancing biomarker strategies can help to improve the outcomes for our patients.